program, KCSI online program, that is Mortality and Morbidity meeting. I welcome everyone for this program. Before we start, I request our chairman, Dr. Narayan Chandra Hebsur, to give the welcome address. Narayan sir.
Thank you, Chandru. I will bring a very warm welcome to all of you. Today's session is going to be done by Dr. Rajesh Ballal. A warm welcome to you and Tejaswini, the mortality meet. And I welcome our scientific chairman, Dr. Kalaivani, and our incoming chairman-elect, Dr. Rajgopal Shanai sir, Dr. Ravi Shankar, and all the participants and the postgraduate students. We will start the session soon. I request Chandru to please take over.
Yeah, this session is moderated by Dr. Rajesh Ballal. He is a professor in KMC Mangalore, and also is the executive committee member of KSCASI and chairman of scientific committee KSCASI. I request Ballal sir to take over.
Thank you, sir, and good evening. A warm welcome to all the senior respected members of the KSI Karnataka State Chapter. Like has been said, this is a mortality meet presented by my junior resident, our junior resident from the Department of General Surgery, KMC Mangalore, Tejaswini. We will discuss mortality about a lady who was waiting for surgery. The idea, I think, of a mortality meeting is to try and figure out as to what we can do better, what we can improve the next time, and whether we could avoid these sort of, if there are any mistakes made. So I will ask Tejaswini to present, and we will sort of keep the questions in the end and see whether we can gain some knowledge. Tejaswini, please.
Yes, sir. Good evening, respected professors and residents. I am Tejaswini Girish, junior resident in the Department of General Surgery, Kasturba Medical College, Mangalore. I'll be presenting the mortality meet under the guidance of Dr. Rajesh Ballal, Professor and Unit Chief, Department of General Surgery, KMC Mangalore. The patient I'm presenting was a 50-year-old postmenopausal female who was admitted to Government Venlock Hospital, Mangalore on the 15th of March 2024 with the chief complaints of pain abdomen and constipation of 2 weeks duration. Pain was predominantly in the right lumbar region, colicky in nature and non-radiating, aggravating on food intake with no known relieving factors. There was no associated vomiting, abdominal distension, or any blood staining in the stools. She also gave history of loss of appetite and significant, however, unintentional weight loss over the past 4 months. She did not give any past surgical history. However, she was hypertensive and diabetic on regular oral medication. On examination, she had a BMI of 18 kg per meter square. She was hemodynamically stable, and on examination of the abdomen, there was fullness noted in the right lumbar area, which on
Tejaswini, sorry, could you move the paper away? There's
yes,
a paper you're holding. Yeah,
yes.
Fine. Keep it underneath it. Yeah.
Yes. On palpation, there was a mass which was non-tender of 10 into 5 centimeters size, occupying the right lumbar and periumbilical area, not crossing the midline, with irregular borders, nodular surface. It was hard in consistency. The mass did not move on respiration. However, there was change in the change in position on right lateral position of the patient. On percussion, there was impaired resonance noted over the mass, and the liver span was 12 centimeters, and no shifting dullness or fluid thrill was noted. Per rectal examination revealed no blood staining or any growth. The left supraclavicular fossa was no lymph nodes were palpable. We made a clinical diagnosis of retroperitoneal mass based on the above mentioned findings, likely arising from the ascending colon. Other systemic examination revealed reduced air entry in the right basal lung field, while rest of it was within normal limits. These are the blood investigations on admission, which show a mild raise in the total leukocyte count and LDH, which could suggest that there was some inflammatory response going on in the body. Ultrasonography of the abdomen showed a large heterogeneous lesion with internal vascularity and cystic components in the right lumbar.
Move your slide, ma. So move the slide next one.
Yes.
You are reading, whatever you are reading, but we are not seeing it.
Okay. So I'll go slow. Ultrasonography of the abdomen showed a large heterogeneous lesion with internal vascularity and cystic components in the right lumbar area and right iliac region, which was likely retroperitoneal in origin. There was moderate ascites which was noted in the ultrasound, which was not elicitable on examination, and there was right side mild pleural effusion. We went ahead with a CCT abdomen pelvis, which showed an ill-defined lobulated heterogeneously enhancing soft tissue density, which was arising from the ascending colon in the right lumbar region with areas of necrosis and cystic areas. And this lesion was seen to be abutting the liver and right kidney. However, it was maintaining fat planes. There was also a similar lesion to the above mentioned lesion, which is abutting the bigger lesion. And there was right side moderate pleural effusion with subsegmental collapse and consolidation. So the features were likely suggestive of neoplastic etiology, which was just arising from ascending colon with adjacent metastatic deposits. And there was additionally lesions seen noted in the both lobes of the liver, which was suggestive of metastasis, and there was also moderate ascites. So we went ahead and got a USG guided biopsy, of which the histopathological examination revealed that it was a malignant epithelioid neoplasm. Now, since the patient was diabetic and hypertensive, she was planned for exploratory laparotomy and proceed once she was deemed medically fit. And during the course of stay of the patient in the hospital on day 4, she developed abdominal distension, which was suspected to be subacute intestinal obstruction. And because of this, we had kept her on clear liquids. And since she was suspected to be in obstruction, the colonoscopy was deferred. On day 7 of admission, patient had sudden onset breathlessness with altered sensorium, and the bystander gave a history of oral intake of liquids in supine position. So we suspected her to have aspirated. On examination, she was tachycardic and tachypneic, and there was a poor oxygen saturation on room air, which improved with oxygen support, and she was shifted to SICU for further management. Her repeat investigations showed an increase in the total leukocyte count, for which the antibiotics were stepped up. Apart from that, no other derangement in the investigations were noted. Her chest radiograph showed a right side gross pleural effusion, which was for which emergency right side ICD was inserted and the fluid was drained. On day 8 of admission, the patient continued to desaturate even on oxygen, and she also developed hypotension. So for that, she was kept on inotropic support and emergency endotracheal intubation was done. However, 3 hours following the intubation, patient had a cardiac arrest and she could not be revived despite 6 cycles of CPR. So the cause of death, the immediate cause was noted to be aspiration pneumonia with type 1 respiratory failure and an antecedent cause of metastatic colonic epithelioid neoplasm.
Kindly stop here.
Yes, sir.
Do you want to ask her any questions, sir, or shall we complete the presentation, or how do you want to go about, sir?
Yeah, I think so. We can have some questions now, and then we can go ahead. Anybody wants to ask some questions?
May I, Dr. Rajesh?
Please,
Yeah.
please, madam.
Yeah, after the clinical examination, I wanted to know what was the clinical diagnosis with which you proceeded. Tejaswini, I just wanted you
Yes,
to
ma'am.
tell.
So we suspected it to be a retroperitoneal mass in the right lumbar area, so probably arising from the ascending colon. So we had maybe an ascending colon growth was the thing that we had in mind. And that's why we went ahead with the CCT abdomen pelvis.
How was the body habitus of this patient? Was she slim, obese?
So she was slim, sir, with abdominal distension.
So
Yeah.
how did you miss a moderate amount of ascites in this patient clinically? I think, because investigations are available,
Yes, sir.
people tend not to examine the patient with the kind of attention to detail that you used to do before.
Yes,
Clinical examination is still very important.
yes, sir.
I think you missed ascites because you probably didn't pay enough attention to that.
Yes, sir.
I think I have to intervene, sir. She did not have shifting dullness. The
Ah.
right flank was occupied by the mass itself. We could not elicit any shifting dullness of the left. We looked for. It wasn't there, sir.
Okay.
Dr. Shanai, sir?
Yeah. So Tejaswini, since you are a postgraduate, I just have to quickly go to your first slide. I will not take much time, but given a choice, we will like to usually present this patient as loss of weight, loss of appetite first, rather than pain abdomen. Better to maintain some chronology, even though there is an argument telling that patient came to the hospital with the pain abdomen. That may be fine. That's why we say HOPI.
Yes.
Okay, that's one. Now next, I will not take but clinical examination, just move that general examination clinically. Yeah, stop here. So that is fine. I know this is not a classical MS examination, whatever, but you should remember,
Yes, sir.
when you are talking about the right lumbar region, when you have written no movement, it's your picture is very clear that we can get the upper border. That is fine. So
Yes.
indirectly, you want to say that it is not liver or something like that, gallbladder, whatever it is.
Yes.
Absolutely missing here is, as one pointed out, is the ascites. So you are big. At least you should mention.
Okay, sir.
Mention means no fluid detected percussion.
Yes, sir.
I know that you have not mentioned supraclavicular node, thinking that it is understood. There is nothing like that. Okay. So instead
She did mention, sir. She did mention. Left supraclavicular, she did mention, sir.
She has mentioned. mentioned.
But okay, all right. That's better to document mention rather than that. Okay. Now, ascites. It is not necessary that you should only shift to the right. That is a classical method. You understand?
Yes,
When
sir.
there is a fluid, your mass is there in the right side. You can also shift the patient to the left.
Yes,
Turning. All right.
Yes, sir.
So that is also one. I'm not trying to say that, but this is one of the methods also described. See, when you have made a diagnosis of a retroperitoneal mass in this patient, correct?
Yes, sir.
Yes. So then we expect you to also give a one or two differential diagnoses. So in your examination, at least one or two, because we don't know. Okay. And when you said retroperitoneum, when you said ascending colon, we don't call it as retroperitoneum. Okay. So even though theoretically one can always argue posterior part is retroperitoneum. No. Ascending colon is ascending colon.
Yes, sir. Correct.
So retroperitoneum means different. Don't include kidney in the retroperitoneum. Okay. Retroperitoneum means we generally suspect retroperitoneal tumors like sarcoma, etc. That is how we look at the situation. One question to you. Total counts were high and you have put an ultrasound guided FNS.
Yes, sir.
Just show that next. My objection for that is intra-abdominal masses or whatever. Yes. So at this stage of initially, after the CT scan, whether colonoscopy was considered at that time itself.
No, sir.
So that is the only other thing which I wanted to tell you that. Then probably we'll ask you some other questions little later. Thank you.
Yes.
Others can intervene.
Tejaswini, see.
Can I intervene
Sorry.
in that, sir? Sorry.
Yeah, please.
Yeah, I know. So to answer Dr. Shanai sir's question, this lady had, even though we thought she had mass in the colon, she had no symptoms suggestive of an endoluminal mass in the colon, sir. So very, very unlike, because she had no bleeding PR at all. So even though this one colonic mass, nowhere we would think of an adenocarcinoma. So I'm not sure whether we should have done a colonoscopy. Just ask.
No, but sir, but there are, she has constipation, she has weight loss, and she's.
True, sir, but for the size of the mass, I think she should have had bleeding PR if it was an endoluminal mass.
No,
this I think was
not necessarily. I don't think that is an alone.
It is
alone will not. Yeah.
It's not about
Constipation and
but you made
constipation.
a clinical diagnosis of ascending colon tumor. I think then maybe before the biopsy using ultrasound or CT guided colonoscopy would have been probably an appropriate investigation.
Could you clinically think of a mass which is arising from the wall, like a gist?
Yeah, I was just about to ask that, Dr.
Large
Rajesh.
mass, relatively asymptomatic regarding the colon. Are we justified in thinking that this mass is arising from the wall and not the lumen?
Yeah, Dr. Rajesh, I was just about to ask Tejaswini. Tejaswini, you mentioned the query just in your slide.
Yes,
Why
sir.
did you think it is just?
Because in the just a minute, sir. in the CT, they mentioned that it was arising from the ascending colon, and later on they've also mentioned that the mass was compressing the ascending colon with like the fat planes were lost. So probably from the wall it was arising.
Wall of the colon you're talking.
Yes, yes, sir.
See, I think the only situation where you can confidently think about the diagnosis of GIST is when patient has had a massive GI bleed, because I think one of the characteristics of a GIST tumor is it bleeds very heavily, and that probably should alert you to the possibility that it may be a GIST tumor. Otherwise, I don't think there are any characteristics which will, until you actually get a biopsy, you will not be able to make a diagnosis of GIST. Or
Yeah.
if it is arising from the stomach, if you do an endoscopy and if you don't see it luminally, then if there is a space occupying lesion in the stomach, which is not visible luminally, then you may think of it being a GIST, because that is the commonest site for GIST tumors, stomach.
So I would just like to add that even if it is a GIST ultrasound guided FNAC for the luminal organs, I am not very sure about the whatever the endoscopy we may do. You may get a ulcer or you may not get an ulcer is a different issue. And if the area of suspicion is there, you can always take a biopsy on a biopsy. That is another issue. So here, and a large size causing constipation and all those what is that symptom list and all that things, anything is possible here. So when we give a thick of a diagnosis, number one as whatever ascending colon, then obviously the second will also go for a retroperitoneal tumor, STS, soft tissue. That's how I think the thinking should go. Obviously, we probably have ruled out, this is a lumbar mass. So a gallbladder liver is ruled out. So then masses can also be just lymphoma. There are so many other things are also possible.
Retroperitoneal masses.
What the adenocarcinoma. Yeah, that's how we look at it. Yes.
Tejaswini, now you go to that slide where, on the day 3 or 4, you said patient developed distension and all that, right?
Yes, ma'am.
Yeah. Yeah. Which day was that of admission?
The abdominal distension she developed on day 4, ma'am.
Day 4. Okay. So when she developed abdominal distension, you as a, this is not for Dr. Rajesh, you as a PG,
Yes, ma'am.
what did you suspect?
Since
A patient who was stable at admission,
yes, ma'am.
and a mass in the right lumbar region, and suddenly on day 4 was stable. Now so when she presented, she did not have obstruction features, right?
No, she did not.
So on day 4, suddenly she develops abdominal distension. And what other features were there?
Just
distension. Then
that's it. Only distension was there.
Only distension. Was there vomiting?
No,
was she able to pass stools? Constipation, obstipation?
She had constipation, no obstipation, ma'am.
Okay. Now this distension was what? Is it significant distension, or how much? Like, was it like? Did you suspect anything else?
There could have been a possibility that since she already had ascites, maybe like the ascitic fluid, there might have been a malignant reactionary fluid that would have been increasing. That could have been another possibility for a sudden abdominal distension other than obstruction.
Which aside
then 4 days it will not increase, ma.
So quickly.
Okay. So in 4 days it will not increase. Okay. Sudden abdominal distension in a mass and with a CT report of suspected GIST as a PG. What will you suspect? We have given all the clues to you. Then we let the discussion go to the faculty around.
Luminal obstruction, because of the if the GIST was like that big, it could have caused luminal obstruction leading to.
Dr. Tejaswini, patient has obstruction from the time she has come to the hospital.
Yes.
Whatever it is, you put it the word chronic. Now, Kalaivani madam is trying to tell if it has gone for acute and a chronic. As a PG, probably one simple investigation you can do. I believe it's in Verloc Hospital. Probably you can also claim some information.
The abdomen could have been.
Pardon? What did you say?
X-ray abdomen to see for.
Sudden
See, as a
distension, no?
PG, you said no features of obstruction. Sir, she said no features of obstruction. So you should think such a huge mass, as Dr. Ravi was telling, you should keep in mind, whether it's true or not is later. You should keep in mind will be a bleed from the huge gist, one of the common causes. Suddenly in 4 days, fourth day she has distension. This is just to be kept in mind.
No,
Keeping
she
this
said,
in mind, we should investigate further.
She had put a query subacute obstruction, and according
Yeah.
to me, patient has come to the hospital with obstruction chronic. This
Mm,
is how
she-
I look at the entire scenario. And
But
now
she said there is
now
no
she has
obstruction,
got
sir.
that. Yeah, but no, what I said is chronic constipation. That itself is enough to make a diagnosis.
Oh.
Now comes this subacute obstruction, then it's slide. So obviously it becomes an acute and a chronic. That's how it is. That's how I look at it. Yes.
Yes.
If it's okay, I think so. We can go ahead, Dr. Rajesh.
Yes, sir. There are only a
Further?
couple of more slides, sir. Because the patient already died. So we reached there already. CPR was given and we could revive her. Sir.
And sir, any other comments from other
Yes,
faculty at
that's
this
what,
stage?
that's what I wanted.
Before we know the exact cause, this is the time for discussion.
Yes.
I think
What
so.
we should think of, and what we should have done, and what was done.
Tejaswini,
Yes, yes.
when you suspected subacute obstruction, did you keep the patient nil by mouth, put a Riles tube, nasogastric tube,
That
drip
is,
and suck, and
yes, sir.
did you do all that?
So she was like once she was suspected, she was not completely kept nil per oral. She was given only clear liquids, and Riles tube was not inserted, sir. Nasogastric tube was not inserted.
Any reason
Did
why?
you do a CBC? Did you do a CBC to see
Yeah,
for any
CBC
drop
30,
in the?
No, CBC showed white cell count 35,000.
34,000.
No, that was initially.
No, not
On the
initially.
day 4.
Yeah, on the day, the
Yeah.
white cell count went up from 13 to 35,000.
Yeah, it is there. They have done it.
Hemoglobin, what was the hemoglobin?
It had
There
dropped
was a drop in hemoglobin.
from 13
to
13 to 11.
11.
Can proceed, I think. If any other comments from other
Just one
colleagues.
clarification, Dr. Kalaivani.
Dr. Rajesh, yes.
Tejaswini was not the PG there. She was. This was.
Oh, she was
unit
not
patient.
there. Okay,
We did. No, in retrospect, yes. I mean, I agree that a lot of things could have been done differently, but an attempt was made to put a Riles tube, right? And the lady, no, we didn't know that the lady will, because deteriorate so early and die.
she'll deteriorate. Unexpected, yes.
But we did try to put a Riles tube, and the lady was not willing, so she was kept nil orally. But I think some liquids were given.
Yeah, just for a discussion purpose, since the high counts 34,900 means obviously she has gone for some kind of a sepsis. Looking at the lesion of the growth, number one, whether it's a small perforation, number one. That's the first thing I would like to consider. Number two, obviously more than bleeding, the second important part for this, obviously the chest. The such sick patients who are lying down like this or coming to the hospital, she might have aspirated little earlier also. It is not necessary. It may be just a coincidence, giving a little bit liquids which patient might have aspirated. Because if you look at that X-ray, whatever is shown, so she may be having the this is what I was talking about. Without white out lung secondary to aspiration, that is what is written there. So obviously, in a patient who is in the ward, patient had all high counts. I'm not sure about the temperature was some 2-3 days, when the patient is being monitored. So perforation is one likely, one possibility. Second, looking at this, obviously such a massive pneumonia with the consolidation, whatever it is, with causing that 34 or whatever counts so high. That's what I can think at this stage. Yes.
Was it a rupture into the right pleural cavity, sir? See, there is so much of fluid accumulated there. Is that a cystic mass which has ruptured into that?
The point against is she had an effusion initially also, sir. The first, if you look at the first CT, even before this acute episode happened, there was an effusion, sir.
Effusion was very, very minimal, if I remember.
Yes. Yes,
But
sir.
this is it is occupying almost the whole of the
True.
right chest wall.
Right chest. True, sir.
And I think so you never had enough time to do colonoscopy also, because the events have happened so fast. The colonoscopy could also not be done. Is it so?
I don't know, sir, because I was thinking that we may not find anything on the colonoscopy, sir.
Okay.
To be very frank.
What was the postmortem report?
And we didn't get any postmortem.
Postmortem was not done, sir.
No,
We
we'll
don't
go in a,
routinely don't do postmortem, sir.
it's, is it over, like, or still
Only one
presentation
more
is
slide, huh?
continuing?
One more slide, ma'am.
One more slide.
Tejaswini, one question. Earlier chest X-ray is there. First chest X-ray.
I've not put it up on this thing, sir.
So this is another thing you should learn, especially cases like this, no?
Yes,
As
sir.
you might have had earlier also.
Yes,
So
sir.
just to keep you informed, mass lesions,
Yes.
ascites, then one more. Of course, you have already got an FNAC report of a malignancy here. Otherwise, you know, tuberculosis, such a rampant disease, loss
Yes.
of weight for this patient, emaciation, and pleural effusion, then pre-existing disease, abdominal mass related to tuberculosis. All this which will come. So please try to get that kind of a comparison so that it will benefit you.
Right.
And what about the saturation at that when this massive effusion happened? Did you, as a PG, did you look for that? You are written respiratory type 1 failure. You have any ABG facilities there?
ABG
I
is
might have missed it. Sorry. Yes. These are just for the sake of learning. Yes.
Yes.
Yeah, 24 per. So accessory muscle. Pulse rate. Look at the pulse rate. So there is something which is, you know, some septic focus. So whether, see, according to me, I still think this small perforation might have happened. That would have triggered the entire episode more than perforation, sudden distension, and aspiration. It is not because you gave little fluid, not that way. Aspiration, you know, a little bit of like that can happen. Even sudden pressure builds up. It might have happened, precipitated. Blood pressure is on the little lower side. Let's look at that. Pulse is going high, very high. Saturation drop. So all these things.
Sorry, sir, your voice is not heard clearly, sir.
Sorry. Is it okay now? Can you hear now?
Better, sir. Better. Yeah, better, sir. Better.
I was just talking about for the postgraduates, you look at that increasing pulse rate going on that way and blood pressure on the lower side for this lady with the saturation dropping down. So with the small kind of, obviously a sepsis, that is the ultimate cause here. What triggered the sepsis? Whether it is the perforation in the abdomen or whether it is a pneumonia. This is how to think about that.
Yes.
Sir, say I think the counts being 34,000, you know, though the pneumonia is there, it's quite a wipe out of the right lung. But generally, the counts of that nature, 34 abdominal sepsis, whether it followed the ultrasound guided whether the perforation happened after the ultrasound guided biopsy is also something that needs to be considered.
Point taken, sir.
Point
taken, because it was not an FNAC. We did a histopathology, sir. So it was like a true cut.
Point
taken, sir. Point taken.
And one more thing, what supports Rajesh, Rajgopal Shani sir view is colonic perforations usually patient deteriorates very rapidly. Fecal peritonitis. Fecal peritonitis, they suddenly deteriorate with all other parameters. So I think could be a perforation is one possibility.
Rajesh,
right, even I mean, with just aspiration, abdominal distension also cannot be explained. Right?
Yes.
This is just for you to, you know, analyze.
Yes.
So what, just to clinically correlate. See, investigations will get, but clinical always, we should keep assessing ourselves every day. Okay, so, yeah.
I feel earlier exploration would have given us the a better outcome rather than delaying it. Don't you think so?
Yes, sir.
Shall
Dr.
we blame-
Rajesh too.
Shall we blame it on the administration, sir? We didn't get theatre, so I must confess, sir. I must confess, I have only 2 theatres per week, so one
Okay.
actually, sir. So,
I know.
But after
Government hospital
distension,
constraints.
yes.
after
See, the-
distension, how many hours later she deteriorated, Tejaswini?
Ma'am, after distension, after like within 24 hours, within 12 to 24 hours, she's deteriorated, ma'am.
So probably she was having a small perforation already, as sir said. She had a pre-existing small perforation, and that is why the mass also had probably increased in size. After the procedure, it further deteriorated. This is just a clinical analysis. We are staying far away. We are just giving what could come, what is coming to our mind. It's not to comment on anything.
Correct.
And I think the other thing is, I don't know what the oncologists feel, but a mass of this size, pre-operative histologic diagnosis probably is not warranted. You can, because it is a large mass which is symptomatic and probably lead to other problems. So resection is
No, probably they
Definitely.
would
Surgical
could do
management.
a CT guided FNAC rather than if at all it was needed.
They
No,
have
the
done a
question,
true cut biopsy only, madam.
question asked is it really required to have a FNAC or a true cut for such a huge symptomatic mass? So there is a
I
question
think,
asked.
yeah, I think for
Early
even,
exploration is probably
say for example,
sir.
even for pancreas, it is not necessary for there it is very clear.
Yes.
Pancreatic head masses, you don't need the histologic proof to operate. Only
Yes.
if it is palliative, when you need to give chemotherapy, then the medical
we
oncologist
need a histology.
demand the histology. Otherwise, it's not necessary.
So this is a right-sided mass, number one. Number two, well away from the liver and the gallbladder as per our picture, and CT also, even though it looks a little closer. Number three, as far as the duodenum is not infiltrated and kidney is normal, ureter is not infiltrated, because what they have written is on tilt, a little bit of mobility is restricted. So what I'm trying to tell is that this might have restricted sometimes during for our decision for surgery, is what I'm trying to put it that way. But again, for the sake of postgraduate, the duodenal infiltration would have caused some amount of, obviously, upper abdominal distension or something. Ureter back pressure is not there. Kidneys are relatively free. So keeping that in mind, these are the things which are, because the size, maybe you were not able to move size. Probably the resection would have been, probably that time would have been best. With, of course, when you have an elective patient. But one point is there, Rajesh, that is, at the time of admission itself, patient had 13,000 count, correct?
Yes.
This is that's why I said whether there is a something
Amount of sepsis somewhere.
She was already in perforation and sepsis.
that is why that
Probably.
constipation, that pain abdomen, all that triggered. That's how the chronicity became sudden acute, and that's how she landed. That's how it looks like. Yes.
Yes.
Rajesh, you would like to give your closing comments?
Yes, I mean, this is what we wanted to do. In retrospect, probably, yes, like has been suggested. But I fully agree with the fact that we probably should have done things a little differently, in that we should have explored. This one against an exploration was, sometimes you get blinded because you have these large masses which you know as GIST. And one previous patient, no, sorry, not one, at least 2 previous patients, the size of the mass has come down remarkably if you prove that it is a GIST and you put them on imatinib. So he's probably blinded by that, but I fully agree with the comments taken that we probably induced the perforation and we should have explored this lady earlier. I fully agree. At least a bypass we could have done if we had explored, if we could not have taken it out. Point taken.
That's fine. I think so. If we are, sir,
I think,
any comments? Sir?
I think a diagnostic laparoscopy to ascertain whether there is, obvious liver mets and metastasis in the, serosal aspects of the bowel and also the peritoneal aspect of the lateral abdominal wall or pelvic wall. So I think a quick diagnostic laparoscopy, and if nothing was there, then an exploratory laparotomy and resection of the tumor probably would have been but I think
Yeah, even
in retrospect, all of us are wiser.
yes,
It
yes.
is, it
But I
is,
think Ravi Shankar sir is making a very pertinent point. The only thing the postgraduate must know, I think, if you must put the first port in the palmous point. Because I
Correct.
don't think you can put the first port in the umbilicus here if you're doing a diagnostic laparoscopy.
Yeah,
But
correct.
sir's point is absolutely well taken. That at least you have some information before you go in.
Yeah, correct.
Visualization was required before only, as
Yes.
early as possible. That's all. Fine. If we are done, I think so. We can.
Shanai sir was
Thanks
telling
for.
something.
Tejaswini.
sir.
Chandru, you're saying something.
No, Shanai sir was telling something. Rajgopal Shanai sir.
No, I think whatever most of the things have been mentioned. So from a little bit finer presentation, plus the trying to understand the mass is due to, if it is a colonic mass, in the examination, try to avoid giving just lymphoma as a first diagnosis, even though present examiners like Rajesh Ballal and myself are more liberal than my bosses. If you tell all these things, come after some time. So in other words, try to say adenocarcinoma. This is how we start looking at the situation. And this next possibility is having given the different, any colon suspected, I think this guided FNACs are to be done only if you have a inoperable situation. I've seen a case of large masses of right lymphosarcoma.
Agree, sir.
Abdominal walls. So otherwise, try to avoid that. And then
Oh.
what is, try to understand that what is happening to the patient. That's what is frequent monitoring. This is very, very important. See, many times we also had encountered no procedure is safe. You do it retroperitoneum, inoperable, ultrasound guided, CT guided, FNAC, people have died. So it's not that, only this happens here, not like that. But your people are in the wards. So that's why we always talk in vitals. Keep temperature, pulse, respiration, BP, abdominal girth, urine output. See, this is how you start learning and see that inform your consultant, whoever it is. Some procedure has happened. So after that, 12 hours, 24 hours, there's some doubtful guarding is there or doubtful tenderness is more. That is what you mean by frequent examination. So this is one of the important things to be taken. Yes. And these are some few comments. Thank you.
And with such a bad lung, how well she will take up the anesthesia and how well she will recover post-operatively also is a big question.
Fine. Thank you, Dr. Rajesh, for making us think too many things and giving us a nice mortality thought. And it was really nice. And it was good brainstorming we had today. I request Chandru to please give a vote of thanks.
Yes.
Tejaswini, it was a good presentation. And
Yes.
Dr. Rajesh, thanks
Thank
for everything.
Thank you.
Thank you.
Sir, we'll
But
conclude this session.
Tejaswini, one thing I always tell all PGs, after examination, please give your clinical diagnosis first. Then only go to investigation. Don't go, it's not examination and investigation. It is history, examination, clinical diagnosis, then investigations. Don't miss the clinical diagnosis. Clinical diagnosis is your diagnosis, your brain and your hand. CT and ultrasound is somebody else's brain and somebody else's thoughts. Okay, give importance to your brain first. That's it.
Yes, madam. With all your permission, we'll conclude the session. On behalf of KSCASI, we'd like to thank moderator Dr. Rajesh Ballal sir and the presenter Dr. Tejaswini for an excellent presentation, and all the national and the state EC members and all the members of KSCASI and the postgraduate students who have attended today's program. Thank you one and all. Thank you very much.